being here this Monday morning, bright and early. What I'd like to do is kind of get started and go through the first part of our what we call our regular group agenda, and then I'm happy to see that there's participation with other invited guests and experts that are in the early part of the meeting. So what we can do is do a quick introduction, because there are faces and people that don't know each other, and then we'll go through the first part of the agenda, and with a goal of ending at 10 o'clock sharp so that we can begin the next section of the meeting. So with that, I'm Diane Feeney, and by the way, the webinar is being recorded, just so that you're aware, and I work with the HSCRC.
Donna Kinzer with HSCRC.
Tracy Laval from the Maryland Hospital Association.
Heather Galano with the University of Maryland Medical System.
Chris Goschel, MedStar Health.
Linda Costa, University of Maryland School of Nursing.
Lenny Preston with the Maryland Women's Coalition for Healthcare Reform.
Dawn O'Neill with the Baltimore City Health Department. Donae Caldoun, the Baltimore City Health Department.
Ed Baranek, Johns Hopkins Health System. Dan Cochran, Adventist Healthcare.
Andrea Benkoski, DHMH.
Trisha Roddy, DHMH Medicaid.
Barbara Epke, LifeBridge Health.
The rest of the Maryland Healthcare Commission.
Tom Valek, I'm a partner with Discern Health and a consultant to HSCRC.
Shurya Chilakol-Gerovich, HSCRC.
I apologize. I think there is a member of the performance measurement work group on. I believe it's Steve Davis. Okay, thank you so much. We will, during the course of the meeting, have a time where if there are people not on the officially on the rosters of the work group, that we will go ahead and ask for comment, and hopefully we'll have time to do that justice. If we won't, we can correspond by email and sort of get any questions resolved that way. So with that, we'll go ahead and move into the agenda. The first item was just a sort of quasi-administrative, was to just do subgroup updates. We do have several subgroups meeting. One was around how to have a quality-based reimbursement program, more real-time reporting back to hospitals, and we've resolved some of those issues. There's no update on that beyond what's already occurred at this point. The next one was efficiency measurement. We had a goal to convene an efficiency measurement work group. That hasn't commenced yet, and we will hopefully get into some strategic discussion about how to move forward with that, with some of the ideas we have around how to address that. The third one was socio-economic or demographic status, and this was to look at a methodology or other methods to adjust, look at quality measurement with socio-demographic factors under consideration. And one of the methodologies we're looking at is using the census tract, the area deprivation index. Allison, our colleague, is working on that work group, and that's still moving along. So we don't have a real update for that, but we are working in that area, and we particularly were interested around readmissions for that group, because there was concern around the socio-demographic factors having big impact on hospital readmission. So the last one was our potentially preventable complications-driven methodology, which is Maryland hospital-acquired conditions, and those are a set of about 65 complications that occur in the hospital. What we have done is we audited some hospital results, because we've seen a really significant improvement in the MHAC scoring over the last year and a half. And there's some big jumps at certain points. So what we wanted to look at is how or if hospital coding of present on admission is driving any of that change. And one of the nuanced components of the audit is that we are looking at hospitals with a change in their early preliminary data versus the final data they submit. So we're looking to see whether there are changes. We did check in with CMS on that issue because they have programs called the HACK program at CMS they don't audit POA. So we couldn't sort of get any benchmark, if you will, information about that. Yes, Barbara.
Diane, did you complete that audit, and could you give us some feedback as to how that went?
Well, there are some potential findings. So what we're going to do is we don't want to do anything until we interact with the hospitals, and then we'll have an update at a later point. But we did want you to know that we had moved forward with that, and there are some things that we're going to follow up on.
Yeah, so we audited 5 audits. We usually audit 10 a year. 5 of them are completed. We are comparing the results to get at least a relative benchmark between the hospitals. A few of them seem like there might be issues with the POA coding, but as you know, it's kind of the rater reliability, so we need to go back to the hospital, review the records with them again, and then make a conclusion after. And the next 5 is also in process, so as we go through it, then we'll get new audits as well.
Right. So is there any other comment about that? Okay. So just about that, we will convene meetings every month to 2 months. Hopefully we'll figure it out around the summer schedule. And certainly into the fall so that we can get the exciting work done that we're going to be getting done. So we want to welcome Albert Wu, who's just joined the webinar. Thanks, Albert. And then I saw John O'Brien. Hi, John. Right here. Hi. And you want to introduce yourself?
Hi, I'm John O'Brien. I'm the Director of Health Care Insurance at Government Personnel Management, former employee of the HR here.
Yes, full disclosure here. With that, what I wanted to do was, Tracy Laval and I had talked about some input that hospitals wanted to discuss around the Maryland Hospital Acquired Conditions performance in the first 6 months of calendar 15. And so I think that's a nice thing to talk about since we are sort of talking about the audit results and all of that.
So just, I guess I'll kick it off to say, and other folks can jump in with a little more color commentary, but I think what hospitals are seeing in this first 6 months is that the rate of improvement or reduction in PPCs is slowing. It's actually increasing, and that's, I just think we should all be aware that it's going in that direction. That there's a couple of things that have been happening along the way. One is that MHA pulled together some groups to get agreement on what definitions of a PPC are. So, like, when do you say that something is a PPC? And one of the most controversial, and I wouldn't say controversial, where there's a lot of variation in when a physician says, yeah, this is a complication, is kidney injury. So with those, we'll see if these are all, we brought hospitals together, talked about what kind of clinical measures they look at to define when a kidney injury happens, and we got some agreement on that. Whether all hospitals will implement these guidelines, don't know. And then also, even if a hospital implements, we don't know whether every physician will take up actually following those guidelines. But those guidelines are now agreed to, so we may start to see some hospitals' PPCs in that direction go up. We may see some go down purely because of changing that definition. So I think we're going to see some instability in PPC rates. So I just want to caution us about that. The other point is that with the PPC rates going up in the first 6 months, I guess I don't know how to explain this exactly. That we just need to be aware, I guess, that these PPCs are potentially preventable conditions, and they're dependent on the 3M software and administrative data. So this is unlike the surveillance kind of definitions, where if you're reporting UTIs, then there's somebody reviewing the entire record and making notes, and this is in and this is out. This is purely based on administrative data, so the rates are not going to be as stable. It's not as reliable. Not to say it's not a good measure, but just that we may get to a point where the PPC rates start to level out, and I don't know where exactly those are going to be.
I'd like to just comment on a couple of Tracy's comments, but before I do, I guess I'd want to see first if you have any reaction to her comments.
Yeah, we do. I forgot to mention that we do have a Maryland Hospital Acquired Conditions clinical work group, and we are working with 3M and the clinicians in various groups around UTI, around kidney injury, and several others. And while there's a little bit of volatility, for instance, in UTI, there was a split in the measure from everybody, whether you had a catheter or not, and now the split is with a catheter or without a catheter. So you see one going up and one going down. So the measure seems to be reliable in that way, in that you are seeing some movement based on a nuance of the measure being split. The second comment I want to make is work through the hospital-associated infection work that Teresa chairs, is that and I'm allowed to share about your audit, right, of surgical site. So they pulled 400 plus cases of the administrative data and found almost 30 cases of surgical site infection in the administrative data that weren't reported to the CDC that should have been, that were SSIs. So let me be a little bit, let me temper, we would temper your comment about reliability. Because what that did was there were measures there. The measure used for MHACs was able to pick up infections that should have been reported that were not reported by the hospitals. There was an 8% rate of surgical site infections not reported. So I think that we've been working using POA and administrative data for years, and I think the reliability gets better and better every year. Now, we need to always strive for perfection. We will never get it, but we need to keep pushing forward, and that's why we have the interactions and input process, and we make real changes to the methodology. We've made them every year based on the clinical input. So that's my comment.
And just let me clarify that those are preliminary results, and we're at the stage where we'll go back to the hospital, show them those discrepancies, and then they'll talk with us, because there's this difference between clinical definitions and the surveillance definitions and all of that.
So Barbara may have some other comments. If you want to go, I have one more about potentially.
Go ahead.
So that's a good example. I think the other one, sorry I'm not articulating this so well, but the other point is about the potential preventability of other kinds of complications. So it's a point well taken on the infections. There's a lot of other complications that are not infections, and I think we're still learning whether the severity adjustment is enough to distinguish between which complications really are preventable and which aren't. And the different PPCs will have different levels of what a good rate is, and that relates to the potential preventability. So just wanted to put that out, that I think we're still in the, as we get this data better, as we get the POA data better, and we get the coding tighter, we're going to find that there are different PPCs with different rates of preventability. So I know threshold benchmarks will take care of some of that, but there's also a piece that we're still a little bit concerned about, and it has to do with small volumes. When you look at that, if you take each month's data, and we look at year to date, if you look at that data, still the hospitals that are at the best performing end are the hospitals that have the smallest volume. And the hospitals at the worst performing end, in general, tend to be the hospitals with the largest volume. So, I mean, some of that could be, you know, if I have only a couple of cases, it's very easy to be right on top of that. Whereas large, you've got to have your whole system working. But it just does raise a little bit of concern.
And actually, you did all the work on that. You covered my concerns. I would add a little bit to that, but because we have statisticians here who are good at prediction and putting all of the data together, that is a question that I raised. I would add a couple things to that. First of all, I think hospitals have really seen PPCs, MHACs as the big challenge. I know at my facilities, that's where we rolled up our sleeves and said, we will do whatever it takes. We will have teams. Certainly we will look at the coders and the POA first, but that goes back a couple of years now. The focus really is a team on aspiration pneumonia, or a team on this, a team on that. And it does seem that the better you do, the worse you do, because the more you are able to decrease. I'm not sure how that severity adjusting works to make sure that we're clear on when there are complications that have a certain statistical likelihood of occurring. The other question, since I'm not a statistician, is how the experience of the large, very tertiary hospitals affects the experience of the small, for instance, in what Tracy is describing about severity adjusting. If the incidence does, the experience in the state does become affected by the larger facilities and the array of procedures performed, does that then lower the bar for the smaller organizations, and conversely, the experience of the smaller, does that raise the bar for the larger? I'm not sure how that works in the individual severity adjusting and prediction, because when Tracy said your smaller hospitals, at the very beginning of the year, the first quarter, you know they're all at the top, and it's very homogeneous. Mid-year, you see an inverse bell curve, because by then, some of the tiny hospitals have had one or two, and then it puts them all the way at the bottom. So the flipping around, I know we're all looking at our scores and our achievement, but the fact that there's a lot of flipping around does make me wonder about the times of the year that we actually judge that performance. So I would just say, if I can bring up questions that I wish your statistical team would go back and review, it would be about experience of large tertiary versus small, and how that fits the expectations and the ultimate prediction for the next year. I think we certainly blew it out of the park in the last year, and I can't say for other hospitals how much of that was due to documentation, coding, et cetera. I'm not even sure I can exactly say at my own facilities, because there's a mixture of quality and adjustments. But the more we ramp up, the harder it is, and you're at the complicated end of quality. So I would just say some of these things we ought to work out now with severity adjusting.
This is Pat Ercolano. I also just want to kind of preemptive the fact that we believe, while we believe this is an extremely valuable program in the sense of patient care, we also believe that this may be time for us to look at kind of the next evolution of the program. So we're putting together a case that we anticipate to present later this summer, early fall. Again, very similar to what we're talking about, but we may be asking to look at these by service lines. So again, very similar to when we're talking about small hospitals and large hospitals. Targets and benchmarks are currently being set primarily by small hospitals because of their performance. And what we're seeing is that certain service lines may drive a higher risk for a complication. And so we would anticipate we would come forward at a later date to try to justify that or demonstrate that.
Just for others who are not very familiar with the methodology, the way we are measuring complications is based on administrative data, and it relies on the prison on admission code. And we've been discussing the reliability on it, but we've been using it for 6 years. The way the benchmarks are set are using the average at the DRG level. So, yeah, I think that there is some going to be discussion about service line and where we are moving, but in general, the case mix adjustment is supposed to control for the risk of a complication for the case mix. So if they have if they are doing more open heart surgery and there is a risk of complication for open heart surgery, the program is controlling for that variation among the hospitals. The benchmarks are set at for hospitals to get a point, it's at the state average. So big hospitals are driving that average. So in order to get a point, that they are compared to the state average driven by largely rates at the big hospitals because they have higher volume to get that average. On the other hand, to get the full point of 10, we look at the top performer hospitals. Again, it's again weighted by the number of cases, but then you are picking a group of hospitals who are performing at the very top. So the discussion there is if the small hospitals are at the very top, then they are dominating the full point that hospitals are entitled to too. So one of the other issues we want to look at is the space between no point and full point, because as the variation gets down, that's getting smaller and smaller, and whether we are awarding big points for a very small difference in the rates. I would say, so we are in the process of hiring a contractor. We are hoping they'll come early fall. So one of the preliminary tasks that we have in their agenda is to look at the PPC variation and statistical reliability. I do caution, I agree with you, I do caution looking at a very small time period. And in the program, we are using 12 months, so we will look at whether 12 months is enough time period to look at. I know TMS differs in some of their measures, and they look at 2 years of data.
Any comments from the phone? Anyone raising their hand? Okay, great. So yeah, that was really good discussion, and it illustrates how we have more really exciting work to do in how the current program is running, as well as and particularly what Pat's comments alluded to, how we're going to move forward to the future. So we're going to just have a 3 or 4 minute break. There is coffee in the back, and I do see some new folks have joined, so we're going to invite them to the table, and then we'll start right around 10 o'clock the next phase.
Sorry, just one more thing on the second agenda, potentially avoidable utilization and reporting. I just wanted to give an update on we are moving towards CRISP to be the only source to get our quality reports out, and I was welcoming the feedback that you have during the how you're getting it and what works, what it doesn't. We align the potential avoidable utilization definitions with the market shift policy. So let me say potential avoidable utilization we define as unplanned care that are avoidable through quality improvement. And we measure that with inpatient readmissions, cost of complications, and cost of avoidable admissions, what we call preventive quality indicators, PQI from ARC. Last year, we also had 30-day ED visits following an inpatient stay. With the discussions in the market shift, since we are looking at the changes in service lines, we added the observation stays 24-hour or more as if they are inpatient. So that when we are looking at your trends, if you are shifting patients from inpatient to observation, we don't have any movement that we see. So to balance that out. With that, what we did is we ran the inpatient readmission logic, including the observations. So in the PAU definition now, there is an inpatient column, but it is different than the inpatient readmissions we are using for the payment policy. So that way, and for the PQIs as well, we are measuring the observation cases where there are PQIs. So that aligned our PAU definition with the market shift. On top of it, we are still adding the cost of complications. So the potential avoidable utilization numbers that were distributed 2 weeks ago are now what we call the market shift calculations. And the PAU definitions are important for market shift because what we are doing in that policy is shifting payment among hospitals if the patients are moving. And you can imagine one hospital doing a good job in reducing their PAU and another hospital doing nothing, or worse, that they have an increasing PAU. In our algorithm, if we don't take that into account, we would move money from better performing hospital to a worse performing hospital. So because of that, we are excluding the PAUs from those calculations, and that's why we want to expand the PAU definition and make sure it's aligned with what we are using in the demographic adjustment. Any questions on the PAU?
That's helpful. Can I just make sure I heard right?
Sure.
So in the PAU report, which is the same as PAU definition in the market shift, observation greater than 23 hours, those cases, they look like an inpatient, and they can be a readmission, they can be a PQI, and they could also be an initial admission for a subsequent.
That's correct.
Right? Okay. Thank you.
And we distributed case levels. I'm sorry. We distributed case level data to help hospitals to work on those. But I expect that we would revise some of the information included there to make it more helpful. So any feedback you have, the earlier the better, so we can make it more useful to you.
One more. I'm sorry.
Go ahead. I was just going to say, I assume you will have the same sort of white paper approach to the methodology when that changes. In the past, you've had a very detailed letter that helps hospitals work with the methodology.
Yeah, Allison Schuster emailed the CFOs before she left. If it didn't
I know what you mean.
reach you, you can contact me. Yep.
One more clarifying question. When we look at a cost of a PPC, that's regression based, and I think those were provided, and the cost of a PQI, is that just the total charges for the case?
Yes.
Okay.
And then there's a deduplication if the case is both readmission and in PQI. Obviously, we are not double counting it.
That's both the acute and the chronic PQI, both in there?
Yes, they're all in. Yep. So it includes all the PQIs, any PQI, I would say. Yep. I need to check. I think it's PQI first. Yeah. In the patient report, you see both of them. When we aggregate it to the hospital total, it varies because if the readmission is occurring to another hospital, that readmission cost is going to the index hospital, and if it is a PQI, it is still staying with the main hospital.
So I think it's deduped at the end in the aggregate,
right?
Not one layer at a time. So you'll see duplication, and then the grand total is deduped.
Okay. Now, I'm sorry. Now you can have the coffee.
Yeah, we'll still break for a minute or two, and we'll try to get really cozy at the table because we have a lot of interest and people here. So
I'll have a cafe latte, please.
Hello, everyone. Sorry to give it and take it away on the coffee, but we've tried to make room for the work group and invited folks at the table, and we're going to, as I said, be quite cozy in this next part of the meeting. So in this next part, this is where we really wanted to have a really substantive conversation about future performance measurement and really think about our strategy going forward. And on the agenda, you saw the 4 questions that we really want to think about as we're going through the course of first the presentation and then the discussion. I really hope that we can hear from everyone at the table because you all bring such an important perspective. With that, what I'll do is ask if we can go through the intros again because we do have some new folks, and it would be great for everyone to know who everyone is. So, and you know well, go ahead. Sorry, Donna.
Donna Kinzer, HSCRC.
Steve Joff from Cmmi.
Greg Tania with the Healthcare Commission.
Ben Steffen with the Healthcare Commission.
John O'Brien with the Office of Healthcare and Insurance at the Federal Office of Personnel Management.
Tracy Laval from the Maryland Hospital Association.
Patrick Alano from the University of Maryland Medical System.
Yancey Phillips from Holy Cross Health.
Chris Goschel, MedStar Health. Linda Costa, University of Maryland School of Nursing.
Lenny Preston, Maryland Women's Coalition for Healthcare Reform and chair of the HSCRC Consumer Engagement Task Force.
Dawn O'Neill with the Baltimore City Health Department.
Jonay Caldoun, Baltimore City Health Department.
Ed Baranik, Johns Hopkins Health System. Dan Cochran, Adventist Healthcare.
Andrea Benkoski, DHMH.
Trisha Roddy, DHMH Medicaid.
Barbara Apke, LifeBridge Health System.
Teresa Lee, Maryland Healthcare Commission.
Lynn Quincy, Consumers Union, which is the policy and advocacy arm of Consumer Reports.
I'm Tom Valek. I'm a partner with Discern Health and a consultant to HSCRC.
Shuri Gerovich, HSCRC.
Diane Feeney, HSCRC, and then on the webinar phone.
It's Albert Wu from the Johns Hopkins Bloomberg School of Public Health.
Steve Davis is also on the work group, and he's on the webinar. And then anyone else? Okay, thank you. With that, I'll introduce again Donna Kinzer. She's our executive director and the best person to go through our overall vision and where she is leading us, and we are going together.
And I'm going to fly through that at the speed of light because we really wanted to get into the meat of the conversation about performance measures. So, one of the things that that we're putting into perspective as we move forward through the implementation of the all-payer model is that a number of things that we're actually working on fall outside of the regulatory purview of the Health Services Cost Review Commission. So as we are working on the various activities, we're looking at what things are a function of our regulatory structure and also organizing activities on a partnership basis with other state agencies and multiple stakeholder groups. So as we're looking at our traditional activities, payment model development is our core historic activity as well as performance improvement measurement. And so what we're focusing on in this context is something that's part of our historic activities. However, it comes with a new context in that historically we were looking at hospital performance, but as we look at the all-payer model, a lot of what will actually make the all-payer model successful is what happens outside of the hospital as well as what happens inside of the hospital. So that takes us to look at the partnerships that we're focused on in the process of implementation of driving forward with care coordination and infrastructure for that work with consumers and consumer engagement, and also with alignment models for non-hospital partners that need to be part of the successful implementation of the all-payer model. And to just put that into a quick 3-year context, because we are working on a very aggressive timeline for change. In our first year, we focused heavily on introducing the new model and doing hospital payment reform, moving to global budgets, engaging stakeholders, and developing regulatory infrastructure and policies to implement the new model. In our second year, which is now, we're focused on the working with partnership activities, focusing on clinical improvement, care coordination, care integration as really the approaches that are going to make the model sustainable, and are really the vision of where we're trying to head with the delivery system changes to drive to where we need to be in the future. And as we move from year 2 toward year 3, we'll move into more implementation in year 3, but also at the end of year 3, we are required to file an application with CMS for beyond year 5. So what will the next 5 years look like in the all-payer model? So this puts us on a very, very aggressive time frame. To dive just one more level into what we're working on right now, the next slide in the deck shows 4 pillars of activities that are going on in terms of year 2 implementation. The first pillar is state-level infrastructure, and a lot of this infrastructure is being created through CRISP and is focused on bringing actionable and meaningful data that we can invest in and deliver on a statewide basis, as well as developing tools to be able to share patient-level profiles at the point of care. And we had a large group of stakeholders and also the state agencies represented in this process. Lastly, we have a large number of providers who are not yet connected to CRISP, and so in order to be able to actually execute on this vision, we need to actually be sharing information from electronic health records across the state. And this agenda calls for connecting all providers through the Health Information Exchange to be able to both share information with them and also to get specific information from electronic health records into the process. And I think that particular aspect really of getting information out of electronic health records might really inform some of the conversation here, because it opens up a new strategy for the future of outcomes measures to begin to drive some of that information out of electronic health records. The next pillar relates to alignment activities, and there are, and is probably the area where we're really starting to dive down into the alignment activities, wanting to push forward the Medicare chronic care fee. We have a very big medical home approach on the commercial side here in Maryland, and the Medicare chronic care fee that started on January 1 would really, if we could get primary care doctors or community-based doctors focused on chronic conditions and through the Medicare chronic care fee, it would start to bring our model more alignment, in alignment statewide on that front. We've been working on some gain sharing and pay for performance programs and ideas, some first steps, and the Maryland Hospital Association has completed one model, and we're working on some others. But I think the conversation that the Physician Alignment Work Group recommended last year was to create a statewide integrated care network that would allow us to move more rapidly in the development of integration and pay for performance models, and that's a topic that we expect to really accelerate in the upcoming weeks as we view the opportunity to be more nimble at preparing to work outside of the walls of the hospital on an all-payer basis. The final item under alignment is that there is a lot of acceleration to move away from volume. The SGR legislation clearly has focused the national scene on getting away from volume-based payment for physicians, and so that's an acceleration point that will be driving our model forward as well as we're looking at the alignment activities. The third pillar is focusing on care coordination. We, together with DHMH, recently made regional partnership grants to focus on developing care coordination activities and care integration activities across regions and across providers and community-based organizations. We have also focused through our annual update process requirement for hospitals to submit a plan for care coordination alignment that will be due December 1, and we'll be having more information going out on that actually today, and then we'll be having more webinars and learning collaborative opportunities around that process. We also have arranged for technical assistance, again, that's being offered in conjunction with Chris. And I think the whole pillar of care coordination is really a necessary approach to focusing the right resources on high needs patients, and is something that all hospitals will need to be focused on with their partners over the next year. The last pillar are the consumers, and as Lenny said, we've been working on some recommendations as well as visiting with consumers and communities around the state to begin the process of explaining what we're trying to do with the all-payer model, but we certainly look forward to those recommendations and more focus on how we will engage consumers going forward. I think this roadmap is important to this conversation because it should be ultimately tying into the direction of where we're going with performance measures, some of them obviously outside the walls of the hospital. and making sure that we're thinking about both hospital quality and performance measurement that goes beyond the hospital walls. And that's the fast view of that area. And
thank you, Donna. What I wanted to just do is pause for a moment and see if there are reactions and comments and any discussion that we need to have around what Donna's just presented. Any questions? Steve, you have a microphone? Okay. Steve Davis is with Fuse. He was on the phone. Now he's here.
And Maryland Psychiatric Society. Yeah, I was on the phone. I'm sorry I missed all the cafe lattes here. So I just want to talk about behavioral health, and that's clearly something that goes beyond the walls of hospitals. When I ran the Department of Psychiatry at Baltimore Washington Medical Center, when the 30-day all-cause 30-day readmission measures kind of kicked in, it didn't take long for us to realize the impact that comorbid psychiatric and substance abuse problems had on things like diabetes readmission, CHF readmission, et cetera, et cetera. And that by itself was responsible for us opening up an outpatient psychiatric clinic to follow anyone who was discharged on the psych or medical service who didn't have psychiatric follow-up. We followed them for a period of time and tried to get them engaged in outpatient providers in the community. So those sorts of things really do have an impact on what hospitals do, and we all recognize the challenge that we have with behavioral health and hospitals and access to care. So I just wanted to throw that out as a marker.
Yeah, I think we have a list, and that is definitely one of the areas on the list. The other one is integration between post-acute and hospital care, of having a very material impact on admissions and readmissions. So I think the integration of behavioral health and the integration of acute and post-acute are there high on the list, along with primary care supports, chronic care supports, and a number of other specific activities that aren't here but are subsections of really care coordination and care integration strategy toward an effective system. So it's not really just about care management, it's really about care integration.
It's Albert Wu. I was just, sort of thinking a little bit about the goal of trying to get more outside of the hospitals themselves, and also thinking about things that are potentially preventable, and thinking about socio-demographic status. I wonder if we can be even more ambitious and think a little bit about other social service organizations. In Baltimore, I'm thinking, for example, about the Helping Up mission that does drug rehab, basically, for hundreds of people at a time. And I'm wondering how we could coordinate with them as well, since they are very likely to prevent readmissions even more than many of our, sort of traditional ambulatory services.
That's exactly why we have the regional partnership activities and focus, that we've really tried to support the community, the hospitals and the non-hospital providers and the community organizations to get together to plan how to address and to integrate thoughts around that, and each community is different. So by focusing on it at the community and region level, we think that has the opportunity to bring forward good thought processes and recommendations, and we do have technical assistance that is made available to those partnerships.
Just a comment. One of the key players that are not called out under care coordination, I think, are the payers, those that are at risk, whether it's Medicaid, commercial payers, et cetera. Their role in chronic condition management, and their role is to make that visible and accessible for their members whether somebody shows up at Holy Cross Hospital or Shady Grove or another, and whether or not Chris can serve as a broker for some time, for some of that information, which is often difficult to obtain.
The payers are definitely on the list, and also as we look at the ACO, MCO, HMO, the payer tends to start to get a little blurry too. So it's heavily in the mix of the pillar of providing infrastructure. The payer is in the mix. Medicaid is very much relying on this care coordination infrastructure to deliver for high-risk Medicaid patients. So you'll see Medicaid at every table to help drive that forward.
Yeah, just to build on that, I really like how the roadmap is laid out because it talks about what gets done. But I think clarifying ultimately who does what and everybody's roles, that's where I think it gets really complex. There's a lot of overlapping roles, a lot of open questions about what goes top down, what goes bottom up. And I think getting clarity around that going forward will be helpful.
All right, great. Thank you. What we'll do next is I'm going to, even more lightning speed, go through the basics of our current quality programs just so that everyone's on the same page who's not usually at the table at these meetings. We have 3 programs that we consider quality-based reimbursement was the first one, 2010, Maryland Hospital Acquired Conditions, and we've talked a lot about that today. Those are the complications in the hospital, then the 30-day readmissions. And then under readmissions, we have a 4th thing called shared savings, and that's just looking at the readmission rates and withholding a portion of hospital payment based on a hospital's respective rate in order to meet some CMS savings goals that are analogous to the Medicare program. The guiding principles are we want all patients to be impacted by the program. We want the high volume, high cost, those in most need to be prioritized. We want the program performance targets to be known ahead, be transparent, so the hospitals, to the extent as possible, can know how they're doing in real time as possible. We want we also want to encourage best practices, and this is perhaps a balance between what one might characterize as competition. There should be quote-unquote friendly competition. The best hospital who does the best job in a particular service line or clinical area should be recognized for that, but also in terms of improvement, a rising tide raises all boats, and best practices should be shared. For the MHAC program, we use the 3M tool. There are harmful events that are not necessarily caused by the person's progression of disease, but something that happened in the hospital. Again, rely on present on admission, and we link hospital payment comparing observed to expected rates by DRG and severity level in a base period. So you compare like patients from one period to another patient, no matter where they are and what hospital. That's the metric. I'm not going to go through the calculation. The readmission reduction incentive program, that is an improvement program, and that we've set a statewide goal, and in 16 we set a goal of 6.76% improvement, and if the hospital achieved that, they got an additional 0.5% in revenue in their payment rate. In 17, oh, go ahead, John. Can you turn on the thingy?
And I'm new to this process. On the readmission, is this benchmarked against national standards, or is this just internal Maryland targets?
These are Maryland targets. We use, as close as we can, a methodology set up by the CMS program for 30-day all-cause. CMS measures more than one type of readmission. We use their 30-day all-cause, including their planned readmission algorithm.
The target is focused on driving down to, for Medicare, driving to the national average
in 5 years.
In 5 years,
and
for the non-Medicare is benched off of the Medicare at this point, and it's actually a more aggressive target than the Medicare, the way the performance metric works.
Okay, so right now Maryland is above the national average for readmission rate.
Yeah, for Medicare.
Yeah. That, I should have said that at the beginning. There's two all-payer model goals. One is to relate specifically to quality, reduce the number of readmissions to the Medicare rate by 2018, because we are above. We're trending with Medicare, and the gap is closing ever so slightly, not as fast as we want it. That's how we are right now. And that's shown in both our data and in Medicare's data. It's pretty close.
Sorry, just one more clarification. So Medicare is trending down as well. So
yes.
Is the target moving along with that, or is it a target that's been fixed in time right now?
It's moving along.
Okay.
Right. Each year we look at the national trend and try to estimate what would be in the next coming year, since we do prospectively.
Yes.
And then we build additional targets so that we can close the gap by the 5th year.
Okay.
So every year we update the target.
So the idea is to end up at the Medicare average in the future, not the Medicare average now.
Correct.
Thank you.
Yeah. Good, great question.
Can Maryland have a goal to be ahead of the national average at some point?
Any state can do it.
Well, and I'll just sort of the comment that I'm going to do for the U.S. Office of Personnel Management. Under us is the Federal Employees Health Benefit Program. That's a $48 billion national program. About 500,000 people in that program reside in Maryland. You are the largest responsibility that we have. The fact that Maryland's rates are higher effectively drives the costs up for federal employees across the country. So if Maryland were lower, you'd actually save money for federal employees across the country. So aggressive movement forwards on this is something that I'm very interested in seeing.
Well, I think it would be really great if you could give us some of the measures so that we could actually look at non-Medicare measures outside in Maryland, because we don't.
We actually have
that would be fantastic if you could share that information back with us, and we could help incorporate that. And I think we do have a high level of disparity in Medicare patients in Maryland. So there are folks who believe that being at average is actually aggressive in Maryland, because we do have a number of folks, particularly in Baltimore City, Prince George's County, who have high levels of disparity. So, but I'm not.
I will put me on the category of skeptical about that Maryland is particularly bad off compared to other states.
We also have some measurement issues that we're working through, so we hope to be able to. I would agree with you that I would love to see us target something more aggressive.
I just want to make one comment. This is, I don't disagree that we want to be a best performer. I think that's clear. Hopefully we could get there. The one point about cost, just want to make sure we're all clear on this, since it's a diverse group here, is under this new all-payer agreement with a cap on the rate at which the all-payer revenues can increase, that savings to payers, whether they be Medicare, commercial payers, or others, is already built in. Because the rate of growth of total hospital revenue had been around 6% for the last 10 years, and the waiver agreement is at 3.58, that cost is already built in. So for Maryland hospitals who are all on global budgets, if we have a bunch of readmissions, we're paying for those. So to the extent that we can reduce those readmissions, then we also retain that savings that goes along with it. So just wanted to make sure we were all clear on that one point.
Thank you. We in 17 our goal is 9.3%, a cumulative goal. So we would measure from 13 to 15 hospitals improvement in readmission rates in order to determine whether there is a penalty of 2% or a reward of 1%, so the stakes are ramping up. We do adjust for planned readmissions and patient severity, but again, we are thinking about socio-demographic factors in the future and how we might use them. And then we also look at observation and ED visits because, you know, if you're not admitting, you may be doing some other things. So, here's the metric, and I'm not going to go through it. You can see it later. The QBR program in 2010 we implemented. It's most analogous to the federal VBP, value-based purchasing program. We have to demonstrate each year to get a waiver from the VBP program that our results and cost savings are equal to or above what Medicare is doing. So our measurement domains, this is comparing Maryland to the CMS VBP program and how the domains are weighted. The clinical area, this is for fiscal 17, the domains name shift, and so I just want to put 1 year up here so you can see for fiscal 17, for the clinical outcome domain of mortality, we're a little lower than CMS. For the process measures, we're at a very small amount, 5%. There's much more of a shift toward outcomes, and then you can see where patient experience is. That's notably higher than what CMS has established at 45% versus 25% weighting, and that's because our experience measures are, the results are low relative to the nation, so we're really trying to focus on improving. And then you see some safety measures and efficiency. Now we have a global budget revenue adjustment. That's what Tracy was talking about. We do an adjustment outside of the value-based purchasing program, but it impacts hospital rates. So we have and that has to do with potentially avoidable utilization that Shule was talking about earlier. We do use that to look at the adjustments. But we want some discussion about efficiency in general and how to measure it better going forward. And then we do a shared savings adjustment, like I mentioned. That's just simply a rate adjustment based on readmissions, and it's just applied to each hospital relative to their readmission rate. Here's some key components to considering the financial impact and how we calculate it. Should we use one measure versus multiple measures? And you see it varies across programs. We have to think about how to convert the rates to scores, how to weight the domains, how to determine the benchmarks, what's the issues related to reliability and validity, for instance, minimum number of cases, what's the practice variation, and what should be in the risk adjustment. And then we have to look at whether we use an attainment versus improvement score that's best, like in the QBR program right now and the MHAC program, or just attainment like we use in the readmission program. And then we want to look at how to look at penalties and rewards, what should be the maximum at risk, and we want to determine what should be the statewide impact. Is it if there are small rewards and big penalties, it saves money. If there's big rewards and smaller penalties because there's good improvement, then it's not revenue neutral, versus should the rewards be dispersed, be gotten from whoever got a penalty. So none of our programs are revenue neutral right now. Yeah. And then I wanted to just show how we progressively increased the revenue at risk for our programs over the years from fiscal 11 to 17. You can see there's a lot more at stake if you add up the numbers. Here's the comparison with the CMS program and the Maryland quality programs. And we were below the nation a little bit earlier on, and now we're catching up and having more revenue at risk dispersed across programs. So the future, we want to talk about those more aspirational things, the population health. How can we meaningfully engage consumers, and how we know that will add to the tipping point of having a transformed system and being more effective in how we use our dollars for hospital care and related care. So and you know, Donna mentioned the electronic health record. So all of those things and many, many more things are in the when we think about the future. And so I don't want to steal that conversation. I just wanted to put the limited list of things we're considering now up here. And then here's the results right now. I'm not going to go through these. You can look at them later in the appendix. But basically, for the QBR program, we're pretty much on par with what Medicare is doing. We're below on patient experience. We're better on 30-day readmission for heart failure, heart attack, and pneumonia. We're similar on a little better on bloodstream infection, a little worse on another infection. So it sort of evens out, I think, when you look at the whole picture of quality in terms of the current results. And we are above on readmissions, as we mentioned before. So I wanted to put everybody on the same page with where the programs are right now, and then hopefully see if there's any quick clarifying questions. And if not, then we can move on to Dr. Cha and to talk to us about the Cmmi strategic vision for the CMS Medicare program.
Just one comment about the penalties in CMS nationwide are across at least a part of the CMS payment to hospitals, but here in the state of Maryland, that is an all-payer system. So 6 or 7% against an all-payer system is quite a bit different at risk than CMS. So.
Yeah, I think the conversation should be focused on what is an appropriate value-based purchasing. What does that mean? And we should forget about CMS, even though they have their program. But we should be talking about it in the context of Marylanders. What kind of a value-based purchasing program do we want to have, and what is the amount of money that should be at risk in value-based purchasing? And well, what is the level that means this really is a serious program?
And also, I wanted to make a clarification. In our programs, there's a potential risk and then realized risk. So sometimes our penalty is 4% on MHAC if you don't hit the state goal and for the worst performer in the past year. So if you assume every hospital improves a little bit, nobody gets that potential at risk. So we would like to also have a discussion about when we think about the value-based purchasing, if we are really looking at how much of our revenue should be attached to the outcomes, do we really look at the realized risk and say, okay, this is the amount of money that hospital is entitled to if they perform on these conditions, as opposed to what we currently have is, this is the amount of money at risk, we are holding it here, and it's a threat to you to improve. So similar to CMS programs, we tend to focus on the stick part of the equation, not much the carrot. So it's always about the reductions in our programs, and is there a value to move that to a more positive construct where a hospital receives the money if they achieve the benchmark?
I'd like to just build off that point because I think it's a really good one, and it comes to what's our really paradigm of how quality works in Maryland. And so nationally, we know that most of the quality programs nationally, and this there's a lot of hospitals nationally. So, but the programs nationally, the hospitals in the lowest quartile get penalized almost no matter what their performance is. But in Maryland, if we think we can do better, if we expect that our performance will not follow a bell-shaped curve where there's some worse performers and there's some super performers and most are in the middle, if we expect to shift that bell curve so that most of the performers are up on the good side, then penalizing the lower quartiles doesn't make sense for that kind of a goal. If you do expect the quality to be in performance in a bell-shaped curve, then penalizing that lower quartile does make sense. So maybe on that larger data set that's the nation, it makes sense. But we're a smaller group, smaller number of hospitals, and I think what we really want is to shift everybody to that good end of the curve. So just fleshing out what Shuli was saying a bit is that if we expect performance over here on this right side of the curve, then let's decide what that payment should be on that right side and set that there. And if no hospitals get the penalty, then fine. But if we have a couple of hospitals on that wrong side of the curve, then they should be penalized. And that is an incentive to move up towards the right side. But I think we really feel that we want to get away from this idea of there has to be a certain amount of penalty applied. So we welcome that conversation to look at the picture broadly.
Well, I want to introduce Dr. Stephen Cha. He's director of the State Innovations Group at Centers for Medicare and Medicaid Innovation. And we're pleased to have him talk with us today about what is happening at CMS in terms of their strategy.
Great. Thanks so much for having me. And just a quick time check. How long would you? I'm happy to skinny down. I just want to be respectful of the other things in the program. Sounds good. So yeah, I'm the acting group director for the State Innovations Group, which oversees the fantastic work that you're doing here. I just came to that position a couple months ago, and I'm on a detail. I still continue to wear my other old hat as the Chief Medical Officer at the Center of Medicaid and CHIP Services, where I've been working on a lot of our delivery system reform efforts. The first quote that comes to mind, though, is something I also worked on. ACA health reform back under Chairman Henry Waxman, worked with the team thinking about, and honestly primarily Medicare reforms back then in terms of thinking about what we're doing. And I think this last comment just reminded me of this, that one of the things that we said at the table was, and one of the most inane but insightful comments that I think was raised was the easiest way to reduce spending is to spend less, right? And so we all sort of had all these contortions about how we're going to hit our budget marks and our scoring marks, and there were very easy ways to do that. And the hard piece was thinking about how do we do that well. And to a certain degree, I'm struck by that when I think about the challenge before all of you today, and as you're moving into this next phase and this aggressive vision that Donna laid out, which I think is fantastic. I think it is at this point where you're the dog that's caught the car at this point, and you have to figure out what to do with it. You've achieved so many of the goals that we've set out in terms of what we talked about, and you're well on track to hit many more in terms of the overall budgetary framework and the vision that you all laid out in a fantastic way when you first engaged with the agency in terms of thinking about what the reshape of your model. And I think the challenge now is how to make that real. And I think the challenge that you have for the remaining years of what you have in front of you are amazing and fantastic. And it's where the real work begins. And I think to some degree, it's the work in terms of how do we connect the integrated delivery network that Donna was talking about. How do we conceive of and stand that up, and connect that and make sure that it's reflected in the work that you all are doing in this room as well, that these are two entities that are coming forward together. So I just talk a little bit about what's happening at CMS and then bring that back around to connect that to Maryland. This is the Secretary has announced her initiative, and I think the catchphrase here is better, smarter, healthier. And that is to say, we'll work across sectors and across the aisle for the goals that we share, which is better care, smarter spending, and healthier people. And I'll be honest, to me, it's a nice talking point. It's a little almost too pithy, and I prefer this slide a little bit more, which is the wisdom of what needs to happen under that in terms of what we're talking about. And I think it really highlights what we're thinking about here in Maryland with you, which is that we need to first think about how do we pay providers better? How do we transition into an alternative payment model that really incentivizes the kind of outcomes that we all want to seek together. And I would say in some respects, with your global payment system, hospital budget system, you're already there. And in other respects, to think about how those incentives flow down to be sure that every entity has the right incentives in front of them and are engaged with the right incentives is really the challenge and the next stage that you all have trying to think about this first bucket. The second bucket is critical, and I think it, again, stems back to the integrated delivery network conversation, is how are we going to improve the way we deliver care? That I think we know, and I think you all know by the fact that your strategy roadmap is out there, it is not enough to simply say we're going to change the way we pay for care and expect good things to happen on their own. How do we identify all the fantastic practices happening in each and every one of your hospitals and each and every one of your institutions, and as mentioned on the phone, on the outpatient and social services side, how do we find ways to knit these together to support our beneficiaries in the most maximally efficient and impactful way possible? That's really the challenge that I think you all have, and probably your principal challenge in your next phase of work here in Maryland. And how importantly, in terms of directly the work in this room, how do you connect that to a metrics framework that really lines up those first and two buckets together? And the experience that we've had, particularly on the Medicaid side of the house, it is really the metrics that have been the linchpin that connect those first and second buckets in terms of thinking about ensuring that the way we're paying providers matches and supports the kind of ways that we're trying to change care delivery in a positive fashion. And then the third piece, and I think a lot of this work is actually well on track for you all, which is how do we distribute information better? And that means both how do we as payers, as a national payers, CMS, provide transparency for our provider partners in terms of transparency and cost and quality information, and also bringing electronic health information to the point of care for meaningful use, both for providers as well as consumers. And so there's a couple different pieces under that distribute information piece. So I think that this three-part framework, I think, in the Better, Smarter, Healthier, it sounds almost, sounds easy, and it's not. And I think that this is the challenge that you all have before you today, and we're happy to be with you and partnering with you. This is the piece that actually attracted the most headlines, not the prior slide. And I think this is the piece the Secretary laid out in terms of goals, that 30% of Medicare payments will be tied to quality of value through alternative payment models by the end of 2016 and 50% by the end of 2018. And I think that goal has been made very clear. And I think that's probably our #1 goal in terms of thinking about this. The second goal, I think, is to try and think about, and this is where the value-based purchasing conversations come in, how do we 85% of Medicare fee-for-service payments tied to some sort of quality or value by the end of 2016 and 90% by the end of 2018. But it's really that first goal that we're really focused like a laser beam on, and not just in Medicare, but how do we work with other payers, other providers, other stakeholders to promote the vision in terms of CMS saying, well, this is our lever that we're going to pull, and are you all with us? And can we find that way to maximize the leverage and the efficiencies by all of us moving forward in that boat together? I'm struck by a qualitative interview that America's Essential Hospitals did with some safety net providers, and they talked about this theme of 1 foot in 2 boats departing from each other, right? And this idea of there is a value-based purchasing boat, alternative payment model boat leaving the station, but a lot of folks are still with 1 foot in the fee-for-service world. How do we transition into that canoe that's moving in the direction that we all believe we want to move in eventually? We know that's hard. We know that's challenging. We believe that through the binding together of the stakeholders and through models like Maryland that we can, in fact, move forward towards that vision. That's a little bit about the Secretary's initiative. The second snapshot I just wanted to give you is the framework of the CMS quality strategy, which has been remaining with us from before the Secretary's initiative and provides guideposts for us in thinking about this. And this is a stakeholder-driven national quality process that came upon the 6 goals that we've been highlighting and outlining in terms of the national quality strategy. And it is a CMS quality strategy, but I want to be clear, this is also the national quality strategy. This is a broad stakeholder engagement effort that came to these. And let me just read them quickly because I think they relate to your work here. Make care safer by reducing harm caused in the delivery of care. Strengthen person and family engagement as partners in their care. Promote effective communication and coordination of care. Promote effective prevention and treatment of chronic disease. Work with communities to promote healthy living and make care affordable. And so this is widely available on our website in terms of multiple documents under the National Quality Strategy. And this has been really the guidepost when we think about what the changes are in care delivery that we're trying to achieve, and how we want to restructure our incentives to support better quality for our beneficiaries. It's really trying to tie together a lot of the pieces in terms of not just that we need to change payment, but what we need to actually do to make care better. there were 4 foundational principles that sort of we felt couldn't be bucketed into a single particular principle, but really foundational across all of those 6 goals. And for instance, eliminate racial and ethnic disparities. We felt very strongly that this wasn't something that we said this is its own goal, we're going to have that in its own bucket over here, but something that had to infuse across all of our work no matter what we were doing. Strengthening infrastructure and data systems, that none of our work was possible without that. To enable local innovation, that this can't be simply a top-down CMS approach, and to foster learning organizations. So, I think that this is just a summary slide of some of our lessons in terms of where we're trying to use some of these pieces, that we're trying to align the measures with the national quality strategy and the 6 measure domains. How do we think about where our measures and the pipeline are? We want to develop measures that are meaningful to patients and providers, focused on outcomes in particular, and I want to emphasize that particularly for you all. Prioritize cross-cutting measures that are applicable to populations. And I think, again, thinking about your challenge here about thinking about a hospital global budget, how do we translate that into promoting a total cost of care population-based? I think this is really relevant. And aligning measures across CMS programs whenever possible, of course, and with states, private payers, and boards. I think that I just want to spend 2 minutes, and looking at the time here to be respectful, on another snapshot. So just talking about the Secretary's initiative and talking about the CMS quality strategy. Obviously, as the Chief Medical Officer for Medicaid for the last couple of years, I've been thinking a lot about Medicaid delivery reform. And I wanted to highlight a couple slides on a particular model within Medicaid, not because it's Medicaid, and I want to be very clear, but because I think it's trying to think about, A, how do we move towards an all-payer type of framework for this, highlighting some of the challenges. But B, I think more relevant, we had a challenge in Medicaid, which was we had a stream of hospital-based incentive payments. I won't get into the details, the framework and the authorities, but we had a stream of money that flowed to hospitals, and we had a programmatic mission and desire to transform that into a population-based, supporting a population-based health vision. And so when I talked about this with Tom and some others, I think there was some desire to say maybe this is worth highlighting for the Maryland model. And again, not to say, and I think very clearly as a CMO for Medicaid, this is not for me, I have a hammer and all the world's a nail, but rather to say this is a challenge that we faced when we went out and tried to say who's doing this and how do we do this. We were coming up relatively blank, and so wanted to highlight some of the lessons that we came to through this process. And this is the first slide on just 3 slides on this, which is the top 10 diagnoses for rehospitalization. So I think this comes back to some of the points that you're raising about behavioral health, the challenges of an all-payer approach. You and Marilyn need to think about both sides of this column. And I think if you look on the left side of that column, it's the stuff that we know, CHF, septicemia, pneumonia, COPD. This is what's driving readmissions in the Medicare space. I don't think any of us are shocked by that list. It's what we think about, at least I think about, when I think about readmissions in Medicare. But if you look on that right side of the slide, and I think there's some corollaries also to commercial payers, it's a very different list. Mood disorders, schizophrenia, diabetes, pregnancy, alcohol-related disorders. This is a different phenomenon driving care patterns and driving the inefficiencies that we're seeking to squeeze out of our system when we think about an all-payer approach. And I think this ties also into, I think, and Albert was raising this on the phone, other institutions that we need to bring into the fold, that it can't simply be about, for instance, a post-acute care setting. It can't simply be about the transition between a care coordinator in the hospital and the primary care. We need to think multifocal when we're thinking about all-payer environment, how to be successful in that. So 2 slides on the snapshot. This is the New York Medicaid waiver, and I won't get into details here, but it's a large system transformation effort under Medicaid. It was an $8 billion investment, to be blunt, over 5 years. And they began the conversation saying this was a hospital-based stream of funding and what they wanted to do with that. We had an extraordinarily in-depth series of conversations about what we were going to do with that particular stream of funding. And it began with their data analytics. And I think similar to Maryland, one of the highest rates of readmissions nationally. And I don't know your numbers, but at least for New York, behavioral health drove 80% of those readmissions. In other words, it wasn't necessarily the primary cause of readmissions, but 80% of the readmissions had some behavioral health diagnosis on that diagnosis sheet. And those drove our design framework. Those that drove us to say, how do we leverage this hospital payment stream? And so I think here are a few key lessons that I think are relevant when we think about the Maryland measurement and framework, which is system transformation. And I think this comes back to the integrated delivery network that conversation that Donna has been driving. And I think we're fantastically supportive of her drive towards thinking about that on her slides in terms of the strategy. But it came to really a realization that we need to think about how do we restructure some of the financing, how do we restructure the care delivery, how do we restructure our information systems to cross settings? That it wasn't enough to say, hey, we're going to set up a regional collaborative, voluntary, and say you guys should all participate together. We tried that, by the way, in some of our prior experiences of this type of environment and got very little bang for that buck, just to be honest. But really, how do we pave the pathway for some of these, our version of those integrated delivery networks to really have some of those obstacles worked out from day one in terms of able to trade payments, able to trade PHI, able to trade care delivery and care coordination across settings. Those three pieces, and again, relates to the Secretary's strategy, not coincidentally. I think it was, again, these lessons that we're learning about what it takes to get this done today. It's not enough simply to say, hey, I hope you're successful, here's some money, but rather to say, how are we actually doing this? The second bullet here is accountability based on outcomes. I think that's what relates to your work. It was the theory of the case there that it was both the state and the provider systems both accountable for improving health, but that the metrics reflect outcomes of clinical foci, and although starting with process, moving to outcomes over time. And that was critical for three reasons. Number one, it gave reassurance to a lot of us that we were driving towards outcomes. But number two, from an operational standpoint, it got CMS out of your business. It got CMS out of New York's business of saying, here's what a good plan looks like, here's what a good plan doesn't look like. We're not signing off on every plan that they're engaging in to think about care delivery transformation, which we were doing in prior models of this. We wanted to get out of that business, and this was the key for us to focus on outcomes when we think about how do we ensure that local entities have a flexibility. I won't get into the details of this, but the last point on this is that attribution goes to the geographic communities, which is to say that it starts from a primary care-based attribution formula, but it goes all the way down. Step 6, and there's a multiple-step formula here. Step 6 is geographic, which is not to say we're drawing little buckets of silos around the state. It does derive primarily from a primary care-based. But this is much symbolic as it is incentive-based, which is to say that everybody has accountability in the system, that everyone's looking out for all Medicaid beneficiaries to have someone looking out for them and thinking about them. So while we were respectful of the system saying you can't hold us responsible for someone in that guy's system and somebody who's never been to us, I think there were a lot of discussions about that in terms of where those dials turned. But it was important symbolically and from an overall thematic piece that this was a population-based approach. So, in terms of where Maryland is on this, I think that, and I do put the Medicare hat on for a second, although the last few slides were on Medicaid, which is that for the Medicare side of the house, it was an extraordinary lift for us as an agency, and to some degree an extraordinary commitment. And again, from the Medicaid side, seeing this go through clearance, I can say from an internal agency, but outside of perspective, I was blown away by the work that was getting done here and the commitments that we were making to Maryland in a good way. And I think that at the same time, it also means that we have an obligation to ensure that we're getting what we need out of this as well from the CMS perspective. And so we need to make sure that we're getting the same, and I think comes back to your points, if not better, in terms of thinking about this. And in terms of hospital VBP and the waivers that you all have from those, similar performance, but some specific challenges, and I think we're seeing with inpatient experience care and readmissions we've already talked about. The hacks, we're seeing great progress, but I just want to highlight that many institutions today would receive penalties under the existing 1886Q, and we are seeing some metrics lag. What do we need to do to transform that? And by the way, I think the answer is your strategy that you're outlining. So while I'm highlighting this, I also want to underscore that I think you're on the right pathway. This is not a bad news slide, but rather to say, these are the challenges you have before you, but rather I think that you are on track to be thinking about this, but underscoring our commitment to your process that I think you're outlining here. So just to say progress is important, and solutions are not immediate. I'm not sitting here saying you should be tomorrow to what John was talking about in terms of vaulting to the top of the national spectrum. But I also want to say we should be sure that the incentives remain strong. That, again, we have the global hospital budget, but the incentives for all the providers and entities underneath that, it's a different incentive structure. And as we think about what that means for any particular individual, that we're rewarding the right guys for doing the right thing at the end of the day. I mean, that's the bottom line of what we're all trying to do together, and that does probably take some thinking underneath that IDN umbrella about how do we ensure that this still happens, to be sure that the folks who are doing well, we're doing well by them as well. So, you know, I think that this is where you all are today in terms of, and I think it was raised on the phone by Albert, I think by the comments in the room, your next phase is really how do we think about moving beyond the hospital? And I think that the amazing progress you've made in 1 year alone just blows my mind, and I want to give hats off to everyone who's been working on that. It's been incredible, and to say that I think that, you know, this is where we should be at this point in time. But also say we have a lot of work to do, and we as CMS want to be there with you to really think through what does this look like. It is hard work to think about these relationships. The last piece I'll just close with, and I'm not going to go over the slide, but it's just to say my father-in-law had a heart attack about 5 years ago. Sat in the ER for 2 hours before being reperfused 5 years ago. He had another MI last Wednesday. And by the way, that was a big fancy California brand name institution. I'm not going to name names, but someplace that we would all think does great. Last Wednesday, he had another MI, and small rural hospital in West Virginia. He's moved since then to be close to us and the kids. And by the time we even heard about it, within less than 45 minutes, he was already in the cath lab getting reperfused. And this was also the day, I think many of you saw the New York Times piece from about the change in patterns of care. And when I think, and I trained with Harlan Krumholtz and some of the Yale gang up there, when I remember his stories and their stories about the culture change that it took to make care different here, that the incredible challenges and obstacles that they faced, it wasn't just about changing payment. It wasn't just about setting a goal for us. It was about the hand-to-hand combat that they had to fight and hospitals had to fight in each and every institution. That's a challenge for you all today, and I have all the respect for you all for taking this on in terms of thinking about this. I don't want to underscore how much of a challenge it is, though, and that was to some degree an in-hospital phenomenon, and hearing about those incredible culture changes. The stories I'm hearing back from New York is nothing but, holy crap, this is amazing in terms of what's happening, but I don't know if we can do it, and some will be successful and some won't. But as you're thinking about this IDN type strategy, I want to underscore that it is hard work. It's going to take time, and we want to be there with you as CMS partners in terms of thinking about this and appreciate all the work that's been done so far. Thanks.
Thank you, Dr. Chow. Thank you so much for that information and your perspective and your ideas about the future and your thoughts about Maryland, all extremely important and relevant to this process. So I want to ask if there are questions and comments that we want to have on the table right now. Is anyone raising hand on the phone? Okay, thank you. I'm going to switch gears and get Tom Valek's presentation up on the screen, and he's going to talk about the gap analysis and relative to our measurement strategy. And just a moment.
Thanks, Diane. I can go ahead and get started while you're bringing up the slides. I'm going to do what I can to catch us up a little bit on time. I can't promise that I'll talk as fast as Steve. And in terms of Diane's point about switching gears, I hope that we won't see the next discussion as switching gears. What I hope that we'll see is a continuation of the great alignment that I observed between Donna's presentation of HSCRC's vision and Steve's presentation of CMMI's vision for the future of healthcare and specifically healthcare in Maryland. And so again, I hope you'll see some of those themes coming through here as Diane's bringing up the presentation. So HSCRC contracted with Discern to provide support to the performance measurement work group, gosh, over a year ago now, a year and a half ago. And I have made several presentations to the work group. So those of you who are the faithful, and there are a few of you around the table, you recall those quality measurement strategy frameworks for population health, for patient-centeredness, for cost of care, and for efficiency, that relationship between cost and quality. And what I'm going to be doing today is bringing all of that together into an overall framework that hopefully will be good background not only for our discussion for the rest of the morning today, but moving into the subsequent strategic planning for performance measurement that HSCRC is going to be hosting. So this is a culmination of that work. If I could have the clicker, or am I just not seeing it? Okay. Thank you. And I should say at this point that this strategy that I'm going to be talking about today is the consultant's recommendation to staff. So I'm not articulating some new strategy that HSCRC has definitely adopted. So the overview of what I'm going to be covering is on the second slide, the dimensions of a framework, and then how we did our analysis in order to inform recommendations. Has to do with compiling all of the current measures and measures that are available to potentially fill gaps that were identified, and then recommendations for next steps. So the dimensions of the measurement strategy, and for those of you who have the handout, you can see this both in narrative on slides 3 and graphical representation on slide 4. So the dimensions are, first of all, we want to pay attention to alignment. You heard Donna and Steve both talk a lot about alignment. Alignment with the national quality strategy aims and priorities, alignment with the strategy of HSCRC, and specifically some focus areas that the HSCRC staff directed us to, and a couple of them that you see mentioned there, end-of-life, outpatient. Also, bringing together the various levels of accountability that Maryland hospitals are responsible for. Accountability internally for improvement and accountability to your communities, but also to HSCRC and the commissioners, and to CMS. The Maryland hospitals report directly to CMS for the inpatient quality reporting program, the outpatient quality reporting program, for example. So how do we reconcile all that's going on? There's a lot there, as we're going to be seeing with the background material. And then knowing that we've got a long way to go to get to the visions that Donna and Steve laid out for Maryland hospitals and Maryland healthcare more broadly, what is the phasing strategy to get from where we are today in the current period to shorter and longer term goals? So here it is in the diagrammatic format. You see the goals at the top in terms of the important quality measurement domains. Then that relates to the various stages, current, intermediate, and longer-term strategy, and all the things that hospitals are currently doing and will need to do into the future along with their non-hospital partners in order to achieve those goals. So how do we go about assessing the current state and identifying gaps and ultimately recommendations? Well, it started by compiling all of the measures that are currently being reported by Maryland hospitals and also potential measures that might be useful. So about a week ago, Diane, in the materials for the meeting, emailed out to you all a mega spreadsheet with several tabs that tried to capture all of the background and the steps in the analysis in this measure compilation or compendium. And I didn't realize it, but staff has gone the extra mile and actually printed out all of this for those of you who are in attendance. So the first legal page that you have is the actual compilation of the measures that Maryland hospitals are reporting by all of the various state and federal programs, some of which Diane walked through, some of which are the federal programs that are sort of in addition to the state-based programs, there are certain contractual requirements, and we sorted these by quality domain, and we wanted to look at feasibility for some of those longer-term goals, so we have a column on data requirements as well. And so this hopefully will be useful background for ongoing planning discussions. In addition, in a second tab, we have measures that might potentially be of use for filling gaps in the future. So as if the almost 300 measures aren't enough for the Maryland hospitals to be reporting or being used for monitoring in Maryland, then there are gaps in what measures might be available. So for example, in the potential measures for future HSCRC use, and these are labeled in the upper left-hand corner, you see the CMS Psych program measures. And I raise that just because there aren't good representations of psychiatric or behavioral care measures in the current programs, and it's been a topic of discussion that Steve raised, that others have mentioned, and when I say Steve, I mean both Steve, that we need to be paying attention to that. Well, so there are options or measures that are already in use as we move toward measures for psych units or psych facilities or beyond inpatient to other behavioral health. That orients you to a couple of the resources that we have here. There's a whole lot in those spreadsheets. I'd be happy to talk with you offline because I know we're not going to be able to get to all the detailed questions today. So then the next step was using this background extensive scan of in-use and available measures in order to do a gap assessment. How to determine what's missing, what maybe could be removed from the programs to make the measurement sets better, and then to get to recommendations for the future. So we assigned all the current measures to the NQS domains that Steve Chaw articulated, and also added some subdomains to the ones that we particularly wanted to do deeper analysis on. And we did both a qualitative and a quantitative assessment. So we did counts of the measures, but counts of quality measures doesn't always get you the kind of coverage of quality measures that you really want. So we have to have made some informed choices too from a qualitative perspective. And then reviewed available measures to fill gaps. So in terms of the domain assignment, you can see the definitions there. I'm not going to read through them all. I do note that somehow care coordination didn't get its definition onto this slide, and that's about addressing interactions between care providers and indicating engagement with system-level reconciliation and data sharing. So that was the definition of care coordination beyond the other 5 that you see here. And so when we put the current measures in use up against these definitions, we found these measure counts by domain. So this was the quantitative piece. And what we took away from this was nearly half of the measures that are currently in use for the HSCRC programs are safety measures. So we feel like we've got pretty good coverage there. And that includes not only the MHAC 56 or so, but also the IQR and OQR is pretty heavily weighted toward safety. So we've got lots of safety measures. That's a great thing. Safety is a good foundation for quality. But what we found the least of were measures for patient-centeredness. And our Maryland modernization under the waiver is all about patient-centeredness, as well as population health and how those two things fit together in terms of individuals and communities and their health care and health. So we really think some attention to patient-centeredness is going to be an important part of the way forward, and you'll see an emphasis throughout the rest of my presentation on patient-centeredness. In terms of population health, we looked closely at the SHIP measures within Maryland because we found that's a really good balanced set of population health measures. Now, a lot of them go beyond what hospitals currently think they can directly influence. So that raises certain questions about using them right now for payment. But as we move forward with all of the points of vision that Donna and Steve laid out. We ought to be moving toward being able to hold hospitals accountable for more of those SHIP measures. In terms of lower cost, there are lots of requirements in here for HSCRC to be tracking costs and working with CMS on costs. Lots of cost-related incentives built into the actual payment programs, which might make the need for cost measures to look a little different. Maybe fewer is fine as long as they're really good and cover the waterfront. So that's something to consider there. And then lastly, in terms of care coordination, HSCRC specifically asked us to look at outpatient, and some of the OQR measures are good measures about what's happening around emergency departments, for example. And the other thing about care coordination measures is you see a lot of them in the secondary designation. A lot of the measures that are labeled as patient safety, like, for example, readmissions, because the CMS, Cmmi partnership for patients labeled readmissions and admission type measures as patient safety measures. The secondary designation would be care coordination, right? Of course, readmissions also goes to cost and effectiveness. But a lot of those secondary designations flow from safety measures being the primary designation. So we thought care coordination was fairly well covered too. So that's the quantitative side of the analysis. In terms of the qualitative side, we decided to dig a little bit deeper in some of the domains that we really felt were important to the way forward for HSCRC and the Maryland modernization. We thought safety, effectiveness, care coordination relatively well covered, as I already pointed out, through the quantitative assessment. Qualitatively and quantitatively, patient-centeredness needs more attention, population health, and lower cost. So in the next three slides, you see deeper dives in those three areas. So we split the domains at those three levels into subdomains to get a better feel for what might be missing. So for patient-centeredness, we split it into experience, quality of life, burden of illness, shared decision-making, and patient navigation and self-management. You may think of some other patient-centeredness subdomains that could be important. We thought these were the most important. And then we looked at the measures that are currently in use and assessed, again, qualitatively, did we think that these subdomains were well covered? Well, almost all of the patient-centeredness measures in use, the CAPS measures, go to experience of care. Some of them go a bit to care coordination, but very few of them go to burden of illness, for example, or patient navigation. So we really think those are places where there are opportunities for HSCRC to add measures to various monitoring as well as payment incentive kinds of approaches. As I'll talk about under the recommendations, these are also areas where the whole healthcare system is struggling to get good measures. So part of the reason why we might not have a lot of available measures in these categories is because either the measures aren't there or the data is really hard to get to. And so that's something that we all need to work on together. But just because the whole country's struggling with it doesn't mean that Maryland's off the hook, because we could take a leadership role here. That's patient-centeredness. So population health. As I said before, these are all SHIP measures, and it's a really good set. And it's not so much about not having the measures or not even having the data, because these are being reported in various ways. It's really about the application of these measures to specific hospitals and hospitals' current accountability, future joint accountability for performing better in these areas across the state, and at what point might you start using some of these that have broader accountability for actual payment incentives beyond just monitoring. So that's the story with population health. For lower cost, we actually have a lot of cost measurement going on within the state programs. And you could hear it as Diane was talking about, and Shule talked about the potentially avoidable use. there's quite a bit of cost measurement going on. Now, we found that that may not be as actionable as it could be because it doesn't get translated into things that hospitals and other providers could readily use, like condition-specific resource use or appropriateness kinds of measures that are more actionable at that provider level. So we can talk a lot about the multiple, hundreds of millions of dollars that are at risk under the waiver and how that gets measured, but what does that really mean to folks on the front line? So we do see some gaps in condition-specific and appropriateness kinds of measurement. The last area isn't one of those domains per se that reflect the national quality strategy, but this area of outpatient care is one of the areas that the HSCRC staff asked us to focus on as we were doing this analysis, because it lends to the idea that we need to start thinking beyond acute care, beyond the four walls of the hospital units, and out into more ambulatory kinds of services, and outpatient care that's hospital-based is a good extension to start with. So we looked at emergency room care, outpatient surgery, diagnostic services, care coordination. This is mostly the OQR measures, the Medicare outpatient quality reporting measures. And actually, it's a fairly good set for at least hospital-based outpatient care. I think if we went to ambulatory care outside into physician office and that direction, another step, we'd see that we really need to start coordinating in a different way. But we can think about building off of these OQR measures for these particular subdomains. So the next step was to scan available measures beyond what Maryland is already monitoring, what the hospitals are already reporting. And the way that we did that was to populate this other table that you saw and compare that, the available measures, with the gap areas that you saw in the previous 4 tables, to see if there would be some measures that could help fill in those gaps. We looked beyond the NQF measures to also the ARC clearinghouse, and there are some international measures out there. And we developed another page that you see here on this mega sheet that is the list of candidate measures. And you see those subdomains where there were gaps on the right-hand side in color that track back to the other documents we've been looking at. And these are just some options that we pulled. And a lot of these, again, had accountability or feasibility issues, which explains why they aren't already, I think, to some extent in some of these programs. But we really tried to focus it in on things that might be possible in the midterm and in the longer term to help fill some of these gaps. There's a little bit more background that I'm going to skip over in your slide set on how we actually identified the available measures. I do think it's important to just touch on the criteria for sorting and funneling those measures. Importance, I think, obviously established through the domains and subdomains. The feasibility, is it reportable through data sources that we currently have or would hope to have in the near future? How would it be used? How would it align as a measure with other programs, other things that CMS is doing, things like Medicare Advantage? So we looked carefully at alignment, and then we also considered measure type, level of analysis, parsimony and measurement, things that you would want to look at in order to get a good balanced measure set for our ultimate balanced scorecard. And what we came up with was 13 measures for what we would define as stage 2, sort of that next near-term set of goals, and 7 measures that are a bit more aspirational, harder to implement. I actually hesitate to call this recommendations. These are really ideas for discussion. These are really directional and maybe examples example measures for how we could go in some of these subdomains. So I don't want to get caught up on the specific measures and, you know, oh gosh, could we do this specific thing or not? But maybe thinking more broadly about what might be possible in terms of these measure examples. So you have one last thing in your handouts, which is the fourth tab for the Excel spreadsheet, which is labeled Measure Recommendations in the upper left-hand corner. And these are the ones that, from that candidate list, we narrowed down based on those criteria that I just covered. So again, some good examples here for important measurement subdomains. Health-related quality of life, for example. You know, functional status is so important to both patients and what providers are working with patients to ultimately accomplish. We need to get to functional status measures. That's the point of these first two. Now, is it low back pain? Is it migraine? We just found a couple measures that went to those things. We thought they were important because low back pain, especially in the commercial age population, is a really important cost driver. Migraine is a really important outpatient consideration. These patients end up in the ED a lot, and it's tough. Both these things are hard for patients. Both these things are challenges for providers. So we picked them as a couple of examples here of health-related quality of life. But the bigger point is we need to work together to get to better functional status measures. And that's not just within Maryland, but that's within the whole country to get at what's important to patients. Second category, burden of illness. You know, we did find a good cluster of measures in the ARC clearinghouse that focuses on burden of illness for cancer patients. You can see more about the measures in the handout documents, but it covers things that are not only important to patients, but also to providers in terms of providing better care to cancer patients. Shared decision making, so important. We use this as an opportunity to point to one of those other topic areas the HSCRC staff asked us to focus on, which was good end-of-life care, that it lines up with patient preferences. So how can we get to that? Well, there's a good set of measures that's a palliative care measure cluster, but also making sure that we have advanced care planning in place. As much as we focused on that as a country over the last 15 years or so, we still aren't there in terms of advanced care planning. A last point about patient-centeredness gets to the navigation and self-management. This goes to communication, something that all providers should be paying attention to, and there are multiple aspects of this NQF endorsed measure cluster, I think, that could be useful in getting our patients engaged and activated in their care. A couple actionable areas of measurement under lower cost. There's a good measure of hip and knee replacement episode resource use. And I know hip and knee is a place where CMS is going to be working with private payers and also NQF and others to get a cluster or composite of measures around those procedures because they're such a big cost driver, so important to patients and providers, but also possibly overused. And so there's an appropriateness issue there that goes to lower cost. And also in terms of appropriateness, we've heard that the maternity population, perinatal care, is so important to that Medicaid side, also to commercial, beyond Medicare. So cesarean section that we know is way overused, and it's actually, with attention, the rates are coming down to be more moderate. But that's a place where we could focus in terms of appropriate use. And then back to this isn't so much a behavioral health issue. It's really more of an elder care issue, appropriate care for dementia patients. We've got lots of overuse of antipsychotics, not only in facilities, but in other settings where we see patients with dementia. So again, examples of directions that we could go that have short and longer term implications. Point being that on the left-hand side, these are ones that could be easier to implement because of available data sources, because they maybe depend a little bit less on patient-reported data. The ones on the right are heavily focused on getting patient-reported information, on pulling the patient into the measurement equation, which I believe is where we ultimately need to go, but it's tough, and we need to be working together to get there. And then to wrap up, a few concluding observations. So one, lots of measures, almost 300 currently in use, and a whole lot more available to fill gaps. How do we use those in the most impactful way? Well, part of it is a phasing strategy to bring in better measures and to, over time, take out ones that aren't moving us in the direction that we want. But the other thing is being able to use some of the monitoring measures that we think are really good for payment incentives. And it's going to require hospitals to take a bit of a leap under the modernization to think outside the four walls, get more engaged with community, get more engaged with patients, and agree to be accountable for a broader swath of health beyond health care. And I've already mentioned the SHIP measure as a challenge area for that. Measure removal. Let's get those topped-out measures and measures where there are better endorsed measures. Just because we've been measuring them and they've been integral to programs, let's not get beholden to that. Let's take them out and put better measures in. Let's look at where we have correlations across different kinds of measures and say, hey, this one could cover what those other 5 actually are currently covering, and get to a more parsimonious, focused set with really powerful goals behind the incentives. And we're hampered a little bit by contractual requirements, by historical precedents and consistency over time periods. But I think we have to keep pushing forward for better and better measures. What can HSCRC do together with the other agencies in Maryland to push for better measures? The measures that would bring in that patient-reported information, the electronic data sources. Measure development is complex. It's time-consuming. It's resource-intensive. But this is a place to invest. And then last, those same agencies, HSCRC and its partners, could pilot some of the innovative kinds of measures. We know that some of those longer-term things aren't ready to bring into incentive programs yet. But how could adding clinical data and testing some of these patient-reported measures really help move not only Maryland forward, but also be an example for the rest of the country? So I will stop there and look forward to discussion.
Thank you, Tom. This is a big mound of measures. I think when we look at the questions on the agenda, let's just not think about the second, third, and fourth one. I think if we can just begin to talk about sort of directional activities that we, working with all of you as key stakeholders and your agencies and entities whom you represent, where should we direct our activities so that we can begin to conduct or develop or build or plan or execute the idealized vision of performance measurement? And that is one that is patient-centered, that is population-based, and that is outcome-focused and encompasses the national quality strategy and the ideals and the constructs, that the pillars that we're already sort of building, or some of which we've built. So that is a massive, hard, nebulous question in some ways. But I think if we maybe go around and we can start here and just ask people to speak about their thoughts about that, then we can get some good ideas down on the list and reproduce that potentially back to the group in something that you can respond to. So Donna, would you like to start?
I guess so. I guess one of the things that I didn't really see here is very much on chronic care, and I think that's at the heart of where we're trying to head. So I think it should be one of the key areas of focus for measure development. So that, and I know that actually Ben has done some work on the chronic care measures last year that I particularly found useful, and we may be able to introduce those into the process of thinking here. But I just wanted to bring that up, the focus on getting patients into medical homes and as a strategy, and so how can we measure the outcome of getting patients into medical homes and getting care plans in place for high needs patients, and really focusing on patients with high numbers of chronic conditions. So what are our strategies, and what can be our strategies in some of those areas? So and I know you focused on episodes, some of the expensive episodes. Are there things that we could do to start really focusing on particular types of episodes, some of the orthopedic episodes, some of the cardiac episodes, where we could begin to deliver episode-based cost data and quality data on a statewide basis? And there's at least 2 or 3 there that we should be able to deliver on earlier.
So it's Albert. Thanks for the really nice, very comprehensive presentation. One of my takeaways from your presentation is that it is important to focus on outcomes, and that's where we have some of the fewest measures, particularly from the patient perspective. And in answer to the question about chronic care, I think that because people who have multiple conditions in particular could potentially have multiple different measures of the quality of care or the appropriateness of care, in many ways it makes sense to go to more integrative measures of outcome. Everyone has outcomes, and your functional status is a sort of the final common pathway that leads to functional status and quality of life. A few things. One is that I was interested to see some of the measures that you selected. There is a lot of interest, but only some work going on so far to turn patient-reported outcomes or patient-reported outcome measures into patient-reported outcome performance measures. And the National Quality Forum and the National the American Cancer Society and others are now just beginning to confront this. But basically, just because something's a good outcome measure doesn't mean it's going to be a good performance measure or accountability measure. So that is something to really just be cautious about. Another thing is that I think that we so I'm very interested in this area. I've done some work personally in the area, but I think there's a difference between what we need to know and what is nice to know. And I think that we should start deliberately. I think that there's a lot of consensus that outcome measures, health-related quality of life measures, for example, are good outcomes, and they're linkable sometimes to processes. I think the burden of illness measures are less clearly linked, and there's less consensus about their usefulness in this area. So I think we should think hard about if we need to measure things in all of these areas, or if there are some that we should start with. And I also think that measuring these things electronically through the electronic health record and ultimately linking back through CRISP, perhaps, may be something that we really should think hard about, because we do have to collect the data, and that's a whole other ball of wax.
I guess 2 suggestions coming from I'll put my perspective as someone who's responsible for the total cost of care in multiple states. And I guess one filter would be around synthesis and priority, that you can get overwhelmed with metrics, and sometimes you want decision makers to know what are the handful of metrics that really drive value. So, I wake up every morning with Medicare Advantage and say, what's the admissions per thousand in over the last week, and that drives a lot of the total cost of care. And I think the other piece, and Albert alluded to that as well, is the notion that the metrics, you can hold the stakeholder accountable for that there's a set of evidence-based actions that are connected to driving improvement in that area, and if they're not, then maybe that's a later version. But I would really want the initial wave to be highly actionable and that we could hold people accountable for.
What I was struck by was you're finding that there really weren't a lot of patient-centered outcomes, which was a conclusion we drew in our patient-centered medical home program. That actually, that definition is particularly foggy and vague, and primary care experts would even dispute often with us whether patient-centeredness was even a primary care function that they should be held accountable for. I think there's generally a lot of work that needs to be done in this area. What I found is that some of the patient-centered demonstrations have really moved on to other dimensions of performance and labeled them patient-centered measures for the purposes of their studies. What I would say, and I think is really important, is to be able to take measures that have meaning at multiple levels within the healthcare system, meaning to providers, meaning to employers, meaning to health systems and consumers. I think that we've not done a particularly good job of that any place in the country, but I think the ability to translate those measures to different stakeholders in the process is really important. Particularly, I think, as we begin to focus on community-based, population-based care, we can talk about what satisfaction looks like at a provider level, but it's very hard for us to talk about what performance looks like, or satisfaction looks like at a community level. I think the Healthcare Commission is very interested in taking many of our provider-based measures and translating those into community-based metrics, which is a challenging operation unless you consider expanding sample sizes significantly. But I think it is, as we move from a provider-only performance measurement system to trying to inform communities on how well they're doing, a necessary step.
Okay, I think I'm going to, first of all, can I compliment the people who did this work? This is really an impressive amount of wading through some really dense stuff. I think I'm going to sort of echo what I think I heard Dr. Wu saying, and also I heard Ben saying, is that we at the FEHB have just engaged, and I will be sharing this with everybody, engaged in a process where we are doing performance measurement for the plans that participate in the FEHB, where we are taking measures which we are holding plans accountable for the funding. So it is of great interest to us that measures that would be here would be ones that would then translate up. I'm not saying that needs to be a one-to-one correspondence, but that's so therefore a signal that we're sending at the top end. For example, and just as where we were talking about before, we are double weighting the readmission rate for our plans as for all providers that participate in the FEHB, and that's tying several hundreds of millions of dollars to that performance. So measures that can then be reported at a plan level are ones that are particularly interesting to us. Just caveat that I'm not expecting all 13 measures that you're doing to be reported at the plan level. And just by the nature of that, the ones that tend to be reported at plan level are ones that are out of HEDIS and CAPS. So I would be interested as this goes along that there at least be several measures that then are easily rolled up to a higher level and then used by other folks so we can coordinate our signals we're trying to send to the system.
So I'm really glad that Dr. Wu went before me because he said better than I could some of the things that I wanted to say. And just to focus on a couple, that is this idea of measuring more at a broader level and an outcome level is a direction that we really like and think makes a lot of sense, particularly as it gets to how are people living with their illnesses and what are providers doing to make that a better experience. What exactly those measures are, I don't know. But hopefully we can work on figuring that out and figuring out which measures are the ones that really make a difference in how a person experiences their health. That's a tough question, which ones really matter. The other points that I'd like to just highlight on, that is one, this idea of data and what's the source of these measures. So one is right now the data that we have that's good is hospital-based, and I think for all of these measures where we really want to get to, we need a broader data source, even if it's not directly coming from the patient, which I know that's probably another step down the road. But even to do, say, a cost of an episode of care, and I think that's a great idea as another step coming, what's the cost of an episode for a hip replacement or a knee replacement, requires data from physicians, from other providers outside that we just don't have access to. So I think we'd like to see that. And I know that CMS and nationally are working towards electronically reported quality measures, ECQMs I think they're called. And there's some bugs in those data. They're not real clean yet, but looking forward to that kind of reporting would be a plus. It could be potentially a much richer pool of data coming from the electronic health record, but also with that richer pool means that those connections and the data elements in the electronic health record have to be right. So there's that piece. I have one more. The last piece. When we're talking about more of a population health measure, a burden of illness measure, or a lot of these measures require assigning patients to a particular provider. So with a health plan, that's kind of already built in, and I think that's great because those measures are out there and being tested, and you're going to get to see which measures are really meaningful. For a hospital, we have to figure out a way to say which measures, which patients belong to which hospital, if you want to hold the hospital accountable. That's a big hurdle to get over, and I know that some ACOs have done that. Medical homes have worked in that direction, but that's something else that we'll need to tackle and put on our short list if we want to get to some of these other measures.
As the knowledge of time here, there are just a couple of thoughts. One, I want to also, I think, reinforce Donna's communication about chronic care measures. Again, that's an area that we're all looking at very deeply. We have a lot of opportunity and a lot of improvement to make in relation to those. One comment is, I think, from a workforce or a stakeholder, I think as a healthcare system within the state of Maryland, getting the medical staff and physician involved in some of these clinical improvements is key for us in the sense of really leapfrogging our efforts. Once we see that we get physicians around a table, they can drive these metrics and these performances far greater than any of us, with all due respect, myself included. The other is patient-reported outcomes. I believe that that's another area that, so again, when we're talking about the joint as an example, you know, what are their patient-reported outcomes seeing and coming back? You know, are we increasing functional status? Are we reducing pain? Those important outcome measures.
These measures, you know, do represent a very significant investment on the part of whoever's doing the measurement. These, at least at this time, not readily available from administrative data. So I think you have to be parsimonious in deciding what to do. But I also think it's important to link across the domains major issues, whether it's knee surgery, for example, around functional status, shared decision-making, cost, and even advanced directives. I mean, if you're going to go into a record and look at something, let's extract the most information we can from it. The other thing is just a reminder that populations are not only made up of episodes of surgical care. And as Mr. Bryan mentioned, understanding the population, you know, how many people go on to knee replacement, and the fact that many don't, you don't measure them as episodes of care. It's important to get an assessment of how populations are managed, not just those that get through to some of these hospital-based episodes.
Thank you. A couple of quick things. Heavily biased MedStar Health towards starting where we are, using what we have, and moving toward the vision that you've painted. So as I think about this philosophically, we talked about where we're still lagging in terms of patient experience and readmissions, and in my own mind, I can see that as a starting platform for expanding, if you will, the voice of the customer and consumers, the population health work that we're doing. I think it's going to be critically important for engagement to paint this vision as an extension of where we are, not an add-on or something new and different that we're about to do. And I think there were very clear ways that were woven today to help do that. That being said, I go back to what Albert and others have said about the critical nature of data, not only data that are accurate, that they're actionable, but that they're timely. So when we get data 6 months after the fact, it's really difficult to get people engaged in the hard work of change. I think the other thing, as someone from an organization that has provider sites in multiple states along the Mid-Atlantic, I think it's important to realize that our geographic boundaries are artificial. When we begin to talk about consumer engagement and population health, we have to imagine that we're not going to be dealing, I'm going to say increasingly, that we're not going to be dealing only with waiver-related issues, that we're going to be intersecting with organizations that are hewing to the CMS expectations. And finally, loving and believing that it's critically important to have patient and family engagement and consumer groups involved in our work. I think it's really important that we sit back and listen to what they say to us so that they're part of it, not that we're doing for them. I mean, I think we need to listen deeply to that voice.
So I definitely echo what you just said about patient involvement, family involvement. I think that's really critical. One thing I was struck, Tom, and great work putting all that stuff together, was the real relative paucity of behavioral health measures. You know, just pulling out antipsychotic use and dementia is a small piece, as I'm sure everyone recognizes. This data from New York showing that 80% of the readmissions are driven by, in some part, behavioral health conditions is something that I think we should all be trying to figure out, well, what are measures that can assess that? And I think back to a work group that I was on for during the behavioral health integration discussions that we had a few years ago. And Hilltop collected data from both the MCOs and the behavioral health managed care organization and put those together. And by putting those pieces of data, those silos of data together, we were able to see that across, we looked at 10 different DRGs, and I'll pick let's say asthma and COPD. Looking at those two DRGs, what we found was that for people who had comorbid mental health conditions, they were admitted, not readmission, just admitted for their respiratory condition 4 times as often if they had a mental health condition versus not. Substance abuse was 7-fold, and if it had both mental health and substance abuse, was 15-fold higher. And that is hidden. There's like this hidden epidemic in there that nobody's looking at because nobody, I guess, stratifies the data. So one measure, an example of a measure would be, pick 3 conditions, I don't know, CHF, diabetes, and COPD, and do that stratification. They have a comorbid mental health or substance use condition, and what are the, pick your measure, what are your admission rates or readmission rates, and you'll see a big difference. The question is, when people are starting to measure that and pay attention to it, then they'll think out of the box about, well, what do we do to address it?
So one of the things that I've always been interested in is chronic care, and I immediately go to medication management after that. My second thought is I always like to, whenever possible, use measures that we already have rather than creating new measures, which tend to be more burdensome to the staff. So just to think about age caps, there's 2 important questions about medications within age caps, which I don't think are part of our quality measures right now. One's communication about medicines in the hospital, and the other one is one of the new Care Transitions 3 measures, which I think is did you understand your medications before you left the hospital? So I'm just thinking those are really, I think, important measures of medication self-management that kind of tie into chronic care.
Thank you. Really exciting to see patient-centered measures being discussed, and not surprised by the paucity of those. And in fact, this is part of the work of the Consumer Engagement Task Force, is to look at these very things. So I'm not going to jumpstart what our work is there. I will say that our final report will go to the Commission in September. So, and Diane and Therese are holding our feet to the fire on this. So, but a couple of things. It's great to see the cultural competence piece in there. I like to think of it as sort of turning it around a little bit and calling it multicultural engagement, because that drives the process in both directions. And I think makes us look at it in a different way. So I would just put that out there. And just on the health literacy measure, that's great to see. And that's an area, I think, where one can step back and look at all of the multiple initiatives that are going on, including the exchange, where health literacy has been deemed such a critical area, where we know that in the previous year, individuals purchased, in essence, the wrong plan and were unable to acquire the care they needed, particularly in the behavioral health community, because they didn't go for the silver plan with cost sharing. So I think that there are opportunities to look at these in a more integrated way and find ways to measure those going forward. Thank you.
Thank you. I just want to start by saying thank you for involving local public health. It's really important, I think, that we see how the sausage is made, basically behind the scenes. But I do want to comment and expand and just thank Donna for identifying the chronic care management, medical home piece. Us for public health, I believe that right now is our hot topic, and being able to prioritize measures that move the needle on population health is really important for us at this point, particularly for funding and managing projects. So you have your own.
I echo Dawn's comments, and thank you for inviting us here today. And my comments are going to I told the line between public health and as a practicing ER physician in the state. So one thing that I always struggle with is when we talk about patient satisfaction, how that does not always necessarily correlate with outcomes. Having been a patient myself, and what I thought was important to me, we all know sometimes that is a narcotic prescription. Sometimes that is the CAT scan. Of course, there are ways to engage the patient and let them know that's not necessarily the best thing for you. But I know that still comes on your patient satisfaction score. The doctor didn't get my CAT scan like I came here for a CAT scan. Why didn't something to throw out there? I apologize. But as an ER doctor, that is something real that we really see. My other, with my public health hat on, is that thing that I did not see was about opioid prescribing. I saw a lot about pain management, which is absolutely important, but something we're struggling with in Baltimore City, as well as I think across the country now as an epidemic, is how is opioid prescribing, which has now gone into heroin overdoses. But how can we incorporate, along with some of those behavioral health measures, appropriate opioid narcotic prescribing in hospitals?
Thank you. I just wanted to touch on a few things that have been mentioned previously. The biggest thing I think we need to be aware of is the availability of data. And it was brought up earlier, to the extent we can use things that are already in existence, I think that's going to be most beneficial to us. A lot of these measures that we're talking about, I wouldn't begin to know where we're going to be able to get this data from the sets we already are working with. So that's a concern. The quality of the data also, as we've seen over time, as we use the data, the quality does improve. Completeness of the data, and then who's going to be accountable. I think we have to take that into consideration for both reporting data as well as we start to develop, I guess, incentive type models around this. Is we're now starting to get beyond our historic hospital walls around this, and how are we going to hold those accountable parties for the performance under these measures.
I'd just like to say, over 30 years I've been in healthcare, and the last 4 have been in the state of Maryland. And in no other state have I ever seen the ability to bring such a diverse group together and have conversations about their communities. So I just want to thank the Commission and all those involved with getting the data and bringing it to this level. It really is impressive, and like I say, it doesn't happen in any other state to this level. And with that, I think just to reiterate a couple of things that have already been mentioned, the data I think is really key. Everybody I think has mentioned the data in one form or another, but not only just collecting the data, but also verifying it, making sure of its accuracy, and then interpreting what it really means, because oftentimes you can see a data point and we make assumptions as to what that is, but there's an awful lot of work, and actually the most work goes into figuring out what does it really mean, and then what can we do about it. So I think that as we add measures, we definitely want to use things that are already in existence to the extent that we can, but then we need to be very careful how we use that data and make sure that it's really driving what we expect it to drive in the end. And I think the other thing gets back to the accountability. A lot of what we're trying to do is build an accountable system so that our healthcare system fulfills the needs of our population. And as we look at these things and how they're measured for, whether it be a hospital, an insurance company, the payers, whoever it is that we're looking at, we have to realize that all these things are being driven by different components within the healthcare system, and who is then responsible for each of those measures. You know, we can't hold a insurance company necessarily responsible for what a physician does, or a physician responsible for what a hospital does, but altogether we need to figure out how those things link and how we get everybody on the same page.
So a big part of what I do for DHMH involves the validity of data, making sure it's accurate. So I echo everything you just said about that, and the interpretation of those measures. So making sure they're measures that have been validated, been in existence a while. The other thing is echoing what other people have said about chronic care and preventative care. I think one of the gaps we have at DHMH for data is the primary care data. We can't see that, so we see the hospital data, but what's happening at the level of trying to find out, are they getting the preventative care from the providers, to find out if they're being treated properly. And also we're seeing so many visits with alcohol for the emergency department visits. We're tracking that for DHMH. And seeing that the behavioral health components related to those alcohol visits, so it's comorbidity as well.
So from the Medicaid perspective, I think the main message I'd like to continue to see is that it has to be all payer. Everything that we're doing here needs to be all payer. And I would encourage Cmmi, when we go back to negotiate it, to not just look at Medicare, but also Medicaid targets in the next waiver. You know, I think there's probably more that can be done around the shared decision making. You know, there's a lot that we're focusing around high-cost patients, and trying to figure out whether we are actually touching the right patients and figuring out some measures around that would be helpful. I think I would love, get some perspective from Cmmi too about episodes of care and how that would get us to our ultimate goal of looking at total cost of care. I know other states are successful around the episode of care, but I don't know how it ties to the overall total cost of care. And it'd be great to, get your perspective on that. With the data, I think, we've been looking at hospital data, and I would challenge us all to incorporate the payer data. We do have claims data on all of our patients. We're preventative care, we're paying for physician care. And I think it's an opportunity, although there's a lag in it, to not hold off on looking at particular measures, but actually try to look at claims data while we're incorporating hospital data.
First of all, thank you for such a comprehensive list of indicators. And when I read them, it made me think of what we aspire to be, not where we are now. Some of them are so highly integrated, and they require more sophistication on some of the more basic pieces of data that we still haven't quite mastered. This far around the table, there's a lot of repetition, but I have to mention the data issue again. There's a tremendous amount of structure and requirement to even get patient perception data to be credible on the HCAHPS side. So I would urge us to do the work that it is required to get to that level before we launch on a process of obtaining indicators that are highly subjective, difficult to gather, and the cost benefit may actually not be sufficient. So I do think we need to look at that. I also applaud Donna's comments on chronicity, and I think what I would add to what's already being said is that we've now put a lot of dollars into population health and community management, and we're going to have to find a way to loop in efficacy and outcome indicators to those entities as well, especially as we are spending a lot of dollars on the hospital and other care side, payer side for those services, and I'm not sure we have done a great deal to look at the efficacy of those yet. And the final thing is certainly the appropriateness indicators are part of our culture change. And I remember certain publications like Choosing Wisely, for instance, takes a while even to get culture to be infused in our medical staff and others, even from Choosing Wisely, which may seem pretty obvious by this time. So I would recommend that we also really continue hard work on that culture change, which will help us limit some of the testing that we do and the services that we do sometimes to prevent litigation rather than just focus on necessary care.
I'd like to echo many of the comments I've heard around the room, particularly the data and data quality. Because we found when we focus on particular efforts like HAI and CLAPSI, and we work with hospitals to educate them, and work with MHA to do the follow-up, so we report, but we also go through a system of encouraging hospitals to address this particular issue. And we've seen major improvements in CLAPSI because of that. But I also think the other issue is consumer engagement. And I think there are developed that consumers would be interested in, and I think you talked a little bit about it with respect to consumer engagement and looking what hospitals are doing now and bring on that. I think that's something that would be very useful. And I also think we haven't begun to exploit all the data sources we currently have, and we need to do that as well.
How long will I keep this all here now? The stakeholders work together this well. You should be enormously proud. I heard a lot, and how much can we ascertain which measures drive value? I think some of the answers is going to be in measuring things at this more population level, as it's been discussed by multiple people, you know. So we have this good hospital outcome. Well, the non-hospital providers, what was their role? And we have claims data, as I think Tricia mentioned, that it could be very useful. And so this could really help, and this that exercise of figuring out what drives value, you could maybe work together to be measuring things at the population level as well as measuring things at the level that's being discussed here. Thank you very much for raising consumer-facing measures. That's an overarching goal that I think I heard earlier, and we haven't done anything to establish what measures will consumers act upon. And there's probably almost nothing in this list that is a measure that a consumer will act upon, because we know we basically haven't gotten across that finish line. So another activity could be to sort of start with the consumer. What do they want to see? What does it need to look like for them to act upon it, as opposed to let's educate them how to use this measure. I think we have pro success rate and we can do it. So that other activity. I heard at last point that we want to get away from, I thought I heard we want to kind of get away from condition-specific measures and also include systematic measures. But then I heard, well, are there measures hone down to just a few measures? You know, people manage what gets measured, and would they cease to signal an overall level of quality and, you know, meeting activity, figuring the way people behave?
This is Shuli Cholokolo. So thank you so much. I think we heard great. So I just wanted to kind of wrap up in a little bit. You know, we are talking about the payments measure. So I do want to kind of take one step before and think about why we are using the measures. For you can have public reporting measures, which consumers can act more easily, hopefully. You have payments measures that we kind of conceptualize that as more looking at overarching quality. All our measures right now is an all-payer, and we don't differentiate service lines, and maybe this is a critical junction to examine those again to see, does it make sense for us to go in deeper and create measures around certain services? Hip knee replacement, do we create a measure that combines efficiency, quality, cost, safety around that service line? Then if we do it, then how do you arrange it, the payment, the value equation there for those services? In terms of data, yes, data is always a challenge, and I'm, you know, it's my day-to-day job to deal with it. But we do have great strength in the state. CRISP can link our records in a record time, and it's pretty much reliable currently, the way that we see it so far. As we are investing in infrastructure for care coordination, I think performance measurement shouldn't be an afterthought. If we are designing the system, like care coordination, if we are touching the right person, maybe we should also invest right at the beginning to think about what measures we would take from that system rather than building another one, leveraging the infrastructure we're already building so that it may elevate some of the data issues that we have that may challenge us for developing measures further. And thirdly, since we are kind of a cutting edge, I do think that if we wait for a measure to be validated, used for payment purposes, then we may miss the boat. I do think that we need to be more smart about how we validate the measures and think about using them. And I think nationally there's a lot of work on patient-centeredness. So we could take some of those preliminary work and see if we could create pilot projects, not a big one, but still start somewhere to measure and start seeing how they work in the real world.
And I think, you know, in the care coordination work group, we did hear some presentations on how people are using measures to drive value. So, for example, how Kaiser Permanente is using measures to drive value and what they're focusing on, and we might be able to learn some lessons from some of the organizations that are actively have integrated care and have a focus on driving value from the process.
Just a couple comments. I think it was a question directed about episodes, and I think this sort of, maybe there's a more general comment, a theme that's come up in a bunch of comments today, but I think, to me, the question of bundles episodes is entirely dependent on the path and the vision that you want to carve forward for yourselves here in Maryland. There's a pathway where I could see bundles being a stepwise piece of that. I can see a version of your future where you skip that entirely and go straight to the IDN. I think that's up to you. And in terms of how we work with you to work that out, I don't think we have strong feelings. I will say I worry a little bit about too many intermediary steps given the task that the IDN is going to be. So I do have a bias, but I will also say that we're here to work with the vision as you all put it together, and I think you all are thinking about these questions. But I think it highlights another piece that's come up, which is that I think as you think about the metrics, it seems to me the question is, what are you trying to do with these metrics, really, right? And so I think there's two pieces of that. One is, what's the entity that's going to be able to use and these metrics as an incentive? So coming back to the questions of, are you holding the hospital responsible or are you holding a physician responsible? I'm hopeful that you'll be holding both of them responsible in some way, shape, or form. So I think, but if you're not, then no, it's not fair, right? So I think part of it needs to derive from the conversations and needs to be integrated between the other conversations that are flowing. So that's the first piece. And then the second piece, and I think you're getting it to some of these appendices slides, is on these charts, it's what are you topped out on? What's your delta on these? Where are the real opportunity gains for you as a state in terms of analytics? And in particular, given the focus you have on readmissions, what's driving that figure? So my example of New York and the behavioral health was New York. Maybe that's not true in Maryland. So I'm not saying it's all about behavioral health, but I am saying that sometimes you need to peel your major pieces one layer below to see what's going on, to see where you want to drive your ship here. So, from our standpoint as CMS, this is y'all's decision, but I do think in terms of when we move forward with you, I think we are interested to know, where is that delta? What are you trying to move? And are you topped out here, right? I mean, I think those questions are germane to us thinking about working with you around these things. And the last thing is just the population health. I mean, there's population health, meaning infant mortality, and then there's population health, and I think someone mentioned over here, just using everyone in the denominator, right? And so those are two different frames of what you're talking about, and I'd encourage you to, I think they're two different conversations, and I think about both of them.
And I will say the bundled payment is not on our priority list, so I want everybody to be clear that it's not there. It's not going to get there. However, I do think that that episodes will ultimately be a potential area to look at pay for performance that goes across the spectrum with a specialist in particular, and so it may be an important measure to bring together to look at all payer performance metrics that can be driven across the provider types, et cetera. So that's really how I think of it anyway. So no bundled payments.
I want to ask if anyone wants to have the last word before we adjourn the meeting. Is there anyone online there? Okay, well, what I want to say is thank you so much. Everyone came with their head in the game, and really thoughtful comments were offered, and we're going to take this and combine it and feed it back and have staff meetings amongst ourselves to figure out how we want to present the next incremental step to move forward with our performance measurement strategy. And we will thank you in advance. Thank you for what you've done today in advance for the feedback you can provide us as we move forward. And thanks for staying late. And sorry about a little bit over time here. Thank you.